Welcome to H&HN Daily. I'm Susanna Hopsolern, Senior Editor for Hospitals and Health Networks magazine. Healthcare organizations are grappling with ways to provide high-quality care efficiently. Utah Health Sciences launched an initiative called Value-Driven Outcomes, which brought together the clinical, business, and technical resources of the enterprise to develop tools to understand patient-level costs for the physician and facility services. Today, I'm joined by Dr. Jim Turnbull, CIO for the University of Utah Hospitals and Clinics, to discuss business intelligence tools for value-driven outcomes. Welcome, Jim.
Thanks, Susanna. It's great to be here.
What's the goal of the Value-Driven Outcomes Project?
I think at the University of Utah, with our health system, we're like many other health systems across the country, where we're really trying to demonstrate value. And I think the title of the project, Value-Driven Outcomes, is really what it's all about. We're trying to figure out if we're going to deliver good outcomes, what's the cost to deliver those outcomes, and to reduce variance in all of our costs across the system, whether it's working on procedures or actually taking care of medical patients who are in for a significant course of care with us.
How can business intelligence tools be used to encourage collaboration between clinicians and administration to manage costs?
Well, I think as we started looking at our data, we realized that there were significant variations in our cost to deliver care. And I think the docs, when they were somewhat skeptical about our costs, they had good reason to be. So as we worked through this, we realized that if we were going to drive out costs, we had to partner, but we had to have data that everybody believed in. And once we reached that stage and we sat down with the docs and we started sharing data, and we started sharing costs, and we started sharing the names of the docs that were associated with those costs and looking at the variance, that was when we could all get in the room together and start actively discussing areas where we had considerable variance. And in almost every procedure and in almost every diagnosis that we were treating, our variances were in the range of about 200%. So we had room to work on. And what we do know from talking with others is that variance is not unusual.
Can you give us an example of a specific opportunity you've pursued?
The one that we really started with, and one that we often use in our presentations, was doing major joint replacements. And in that area, it was pretty obvious that we had about a 200 to 300% variance between, from the mean. And some were lower, some were higher. But I think what we were able to identify is that really based upon a doctor's preference, the cost could vary significantly depending on the device that they wanted to use. The radiology tests that they would order, the lab tests that they would order, there was significant variation from physician to physician. But the data really became the focus of the discussion rather than sort of debating with each other as to who was the better doc. It became how to reduce variation in the procedures and in the approach to taking care of our patients. The next step for us, though, is to really start drilling down into several different areas, orthopedics being one, women's and children's being another. And in the neurosciences area, we've brought additional focus as well. So we're trying to really grapple not just with the outcomes that we traditionally measure, but what are the outcomes that we should measure. So that's really the next stage in the project. We've got the costs nailed, but now we need to go back and look at what are the true outcomes, and then our equation is value equals outcomes divided by cost. So that's the direction we're headed, and that's the next part of the project.
Thanks for joining us today.
Thanks for the invitation, Susanna.